Okay, so we will have Nir Uriel from Colombia, another leader in our field, who is going to talk to us about what device tailoring medical therapies for cardiogenic shock and the role of microcirculation. Nir.
So, first of all, good morning, everybody. And Marwan, what an amazing meeting, and what an amazing, actually, interest that people have in the field. So, after Esther, actually, I think the talk is perfect because let's try to dream a little bit different. We have what we know to do. We know how to use SWAN, we know how to use clinical, but this is the real thing. Now we have classification. Everybody already screaming sky, and they know that sky is going to be correlated with outcome. However, the question that we need to ask ourselves is really, how do we choose? What do we choose? And the question, did we look at it from the other direction? So I'm not going to give you answer, okay? I'm just going to cause you to think differently, and maybe a few years from now, we'll come with a different answer. Perhaps looking at macrocirculation, that's what we usually look, and treating according to current hemodynamic is not enough, and we need to look closer. So what do I mean by looking closer? What I mean by looking closer is looking at the microcirculation and really trying to understand that there is, whatever we do doesn't happen in the aorta or the main artery, it's happening in the smallest blood vessel in the body that deliver the oxygen and the nutrition to our tissue. So when we think about it in heart failure and cardiogenic shock, there is a lot of activation of multiple systems. As a result of this the sympathetic system, we have a vasoconstriction that's going to affect, of course, the big blood vessel, but mostly the small blood vessel. And when those small blood vessels that doesn't have a lot of resources, there are going to be hypoperfusion that's going to happen, and then end organ damage. So when we think about end organ damage, we think about the kidney, we think about the brain, we think about the liver, then immediately we try to understand what's happening, and they produce lactate, and we said, whoa, we have end organ damage. But this takes time. We are actually too late. So maybe we need to go back to those microvasculature and understand, can we measure the microcirculation in a bedside in a manner that we're going to assess cardiogenic shock. So let me give you what is a microcirculation. This is a glycogel device. It's one of the microcirculation devices that we use. We now test in other devices as well. It's a dark field imaging. It's visualized capillary and their blood flow. It's a sublingual. As you can see, it looks like a gun. You put it below the tongue and you mark, and you're actually trying to, I isolated 3,000 capillaries. When those capillaries are isolated, as you can see here, we actually identified several parameters, and I'm not going to go in depth into it, but we are looking at the microvascular density, how many capillaries we see in an area. We look at the capillary blood volume, the blood volume inside the capillary. We look at the profound boundary region. This is a little bit tricky because the other two, the more you have, the better it is. The profound boundary region is actually the size of the capillary. And if you have injury, actually, the glycohelix is being injured, and you're going to have a wider capillary. So wider capillary here is going to be the profound boundary region. The higher it is, the worse it is. This is different. We're going to look at the flow, and from all of this, we are going to be able to calculate the microvascular health score. So now, let's understand what's happening in cardiogenic shock. And this is a work that's done by one of our research fellows, Salwa Marwan. And this is a cross-sectional, just whenever there is a shock patient, she is run into the unit and she do the microcirculation. And as you can see, first of all, the total vessel density is down substantially in shock. The capillary blood flow is down, the flow is down. As a result, the microvascular health system. I didn't jump on the perfused boundary region. Shock is an acute event. There is not enough time for the glycohelix to get damaged, so that's the reason it's very similar, as you can see, with that. So now let's try to understand in the sky if we can see different level of shock in the microvascular, and exactly the same thing. The total microvascular density is coming down, the more the sky is heavier. The capillary blood flow is down. The volume of the capillary is down, and the result, the microvascular, look the difference between the sky E and where is Bill? Bill, this is the patient that you spoke about. There is no microvascular health here. It's completely collapsed. And as a result of it, we can actually try to think what is the difference between devices. So still, the challenge that we have in our response to shock is supposed to be so fast that the people that come to put the ECMO sometimes is faster than my research fellow that come to do the microvascular assessment. So we don't have pre and post on all of them. We're collecting, we'll have it soon. But as you can see, the patient that received the ECMO, we don't know it's because of the ECMO or as a cross-sectional, we just remember the cavity here. We definitely see that the intra-aortic balloon pump and the Impella have similar, I will call it microvascular health. Similar also to inotrope, but the patient on the ECMO, again, maybe they were sicker, have more. Another thing that we look about is actually the VIS, to look a little bit on the vasoactive medication that we're giving. The more VIS score we have, it's very similar. We are paying a price, okay? So we need to get rid of all those vasoactive medication because they immediately associate with reduce in the microvasculature. So just to take us for a different field for a second, the last minute, and to take you where we take it, because the challenge to do it, cardiogenic shock microcirculation study, is still that it's a research. Now we are training the resident to do the test, so maybe we'll have some more data next year, Marwan. Hopefully I will have more data to give you about that. But if we will take it from the LVAD field, that here it's not a problem to do pre and post, you can definitely see that continuous flow unloading improve microcirculation substantially. And this is just to show you how it's look. You don't need to be a genius to understand this is a patient with cardiogenic shock before the LVAD. And actually it was an Impella, so just to see even the difference between Impella and the post-Impella on the post-LVAD that actually getting off. But what I want to show you is actually the trick that is more important. Is actually, if we look at the microvascular health score, the summary of all of it, and we split it into below 3 and above 3, that 3 is normal, and we have patients that are normal and abnormal. Actually, from cardiogenic shock perspective, we would have said they have the same macrohemodynamic, the same CVP, the same systolic PA, diastolic PA, mean PA, the same cardiac output, the same cardiac index. But the microvasculature already successfully identified that even though those people have the same ester hemodynamic, they actually don't have the same microcirculation. So this is probably when we need to start going. So just to summarize, this is us, the control, and of course heart failure patient going a little bit low, cardiogenic shock completely collapse. LVAD succeeds to fix it, and I don't want to go in this talk to what transplant is doing, but of course tacrolimus affect microcirculation and it's damage it, but definitely this is where we need to go. So again, when we want to understand how to deal with cardiogenic shock, we need to better cardiogenic shock staging using this to guide inotrope therapy, to look at MCS implementation, what they do pre and post, and then maybe advanced therapy and timing. But the direction is to try to find it earlier. Lactate is too late, and macrocirculation is actually not differentiated enough. Thank you very much.
Excellent. Thank you, Nir. So this is open now to questions. Amanda, please.
It's really fascinating, and I haven't heard this topic talked about before. And I'm just trying to think if it intersects with something that we have coming out in publication anytime now, which is epidermal lactate measurements. It turns out that when you're in heart failure, your epidermal lactate actually goes down. Compared to a healthy control. And we looked at in a cohort of VAD patients over 3 and 6 months post-VAD implantation visits, that it comes back up towards where a control is. How that all plays in, exactly why that happens, why the epidermis would respond in that way. Do you have a sense of like what's going on in the microvasculature here and then the way that it, really impacts the tissue around it?
Yeah, I think it is. And again, there is now a lot of speculation that we can say. I have to say that for us, the interest in lactate starts with work by Nikhil Narang, that is from Chicago. And during the time that Nikhil was a fellow, we started measuring all those lactate and correlates them with shock, and exactly what you just spoke right now in the timing. So when the lactate is already elevated, we said, okay, we're in shock. But if the lactate is normal, it didn't mean that you were not in big shock, and this is going to exactly what you're describing. So that's the reason we need to ask, why is the lactate secreted? And that's the reason the interest in microcirculation. Microcirculation drives the hypoperfusion injury that drive the lactate. Now, why the endothel is going down and going up? This is going to the profound boundary region that I was speaking about a little bit. Again, it's a 7-minute talk. I cannot speak in length about profound boundary region. But there is damage that happens on the endothelial level in cardiogenic shock that just take a little bit more time compared to the rest of the damage.
Thank you. Dr. Walt from the University of Pennsylvania.
Thank you. Great job, Nir. Hi, how are you doing? So we actually also are doing microcirculation in cardiogenic shock called the Micro-C shock study. And we are measuring it in 4 different time points prior to temporary MCS and then 3 time points post-temporary MCS. Not to scoop the conclusion, but we're finding similar things as you and Jacob Nuclea. Our medical student is going to present the data tomorrow, so come and look at it.
Great. Thank you, Joyce.
There's a tough one coming from Germany.
Oh my God, Evgeny. Okay. Protect me. Yesterday I tried to put my hand in a armbar.
The lactate is produced in the body and utilized in the liver. How it's to judge this lactate? It's a problem of the too much lactate in the body, or the liver is just not working and does not utilize lactate because of this microcirculation problem?
So first of all, I think it's a comment, it's not a question, because I think you're right. There is two elements that are happening. First of all, we produce lactate. The more shock we have, the less perfusion, because microcirculation is affected. We have higher lactate, but we need to clear it. And if the clearance doesn't happen, this is always how much we do and how much we don't. I just feel that the lactate is too late. I think we need to start thinking. I'm not knowing if it's microcirculation. Maybe it will be something else. Something else that will be earlier in the cascade to guide us, because the tissue damage started when there is lactate, it's already happened. It's late.
Good. Irving, quick comment.
Nir, a couple of questions. One, maybe I missed it. The images that you showed are images of which part of the body?
So what we do, we put the camera below the tongue, and we take 3,000 capillary below the tongue.
Okay, the tongue.
So it's actually sublingual, if you want to think about it. The tongue is a very vascular body. It's so easy to get a capillary. I have to say, in the machine, and Joyce, I will be interested to hear from you, your experience. In the beginning, we were successfully to do it in 5-7 minutes. We will get 3,000 capillary, and then artificial intelligence, by the way, is the one who read it. In the past, we had to do manually when whoever did microcirculation research start in the field for 10-15 years ago. Now it's AI is taking and it's do all the calculation. So I will say to you, it's sublingual, 3,000 capillary.
Very quickly, please introduce yourself. We have the lights and we can't see.
You can't see me. It's Marv Slepian.
Hey, Marv.
Nir, great stuff. Listen, let me ask you about sort of a chicken and the egg phenomenon, which you really need to start to think about. You know, there are many patients that have pre-existing microvascular disease, particularly diabetics and, you know, many other inflammatory vasculitides and other things. So I think, you know, clearly the heart is driving, but it would be very interesting to look at those patients who have pre-existing small vessel microvascular disease versus a generally healthy endothelial cell group, or even those patients that, for instance, take arginine and other things like that. Those are all factors which could modulate the response that you're going to see.
Nir, we're out of time. Very quick.
Very quickly. Marv, I think you're 100% right, and what we are seeing even in the control, for example, because everybody volunteered to be a control, we know that if you drink coffee, for example, it's going to change your microcirculation. So there is a lot of things that change microcirculation, like in anything in cardiology, the trajectory is going to be a crucial, and that's the reason the beautiful of what Joyce just said, and the longitudinal aspect of multitasking is important. I think that, again, if you have microvascular disease to begin with, if you have shock, you have less reserve. Your lactate is going to go much faster here because the damage is going to appear earlier.
Great.
Nir, quick question.
Yes.
Is there any difference in microvascular flow from balloon pump and Impella?
Yeah, actually there is. Again, I didn't go to the nuance of the things. There are differences. But again, the challenge that we have is that there is a patient that we choose to put a balloon pump, and there is a patient that we choose an Impella, and they're not equal. So I think the depth of the shock of those patients, and that's the reason I showed the analysis on the VIS score and the SCAI, because I think the beauty of it is now is exactly like Joyce is doing and we're doing a prospective study to really understand it.
It's a steady flow. There is
Continuous and
continuous
I
flow
knew where
there.
you're going with it. Yeah. But to
Yeah.
remind you, even us in the capillary, we don't have pulse.
No, I understand.
Excellent.
Just-
Excellent.
Okay.
We need to
Good.
repeat it.